It's 3 o'clock. I'll go ahead and call this meeting to order. Board members present. Sherry's here, Shelley's here, I am here. Rich is on the phone. However, Rich, we don't have you listed as virtually, so it looks like you won't be able to vote, but you'll be able to participate.
Why is that? I gave my address to Deborah.
I think she thought you were going to be here in person for this meeting.
Yes.
Rich.
Exactly.
And Ken is not here. He's not able to join us today because he had a conflict that he couldn't get out of. So let's go ahead and rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Okay. Item number 4, modifications to deletions from the agenda. I have none. If no one else has any, then I would go on to approval of the agenda, and I would accept a motion to approve.
I move approval.
Thank you, Sherry. Second.
Second.
Thank you, Shelley. All in favor, Sherry,
Aye.
Shelley,
Aye.
and I'll vote aye. We will be meeting in closed session pursuant to Government Code 54956.9D1. Conflict of legal counsel, existing litigation, Velez versus SHD, the same code. Existing litigation, Robles versus SHD, Health and Safety Code 32106, report involving trade secrets. Health and Safety Code 32155, hearing subject matter report from Quality Assurance Committee. Government Code 54957B1, public employee performance evaluation for Chief Executive Officer. Government Code 54957.6, conference with labor negotiators, agency designated representative, board chair, unrepresented employee, chief executive officer. And with that, that moves us into our public comment period. As a reminder, comments are limited to 3 minutes, and this is for items that are not on the agenda. I don't believe we received any written comments ahead of the meeting.
No, we did not.
Thank you. Do we have any comments in the room or online?
Just out of curiosity, financial, if you have someone that comes to use the facility, that's a VA, do you charge the VA or do they have to?
Submit
Do
for reimbursement?
they have to submit it themselves to get reimbursed?
It's a good question. I don't know the answer to that. Do you know the answer to
You
that?
know, Steve, are you on? Let's get Steve, the CFO.
Just curious,
I'm not sure exactly. I know there's reimbursement. I'm not sure.
because I mean, you bill other insurances, and I know Aldine is really upset because, well, she gets upset over everything anyway. But she does with the VA and I
Let me ask
guess
that.
when she comes here, you don't.
So there's,
get
so
the-
until if he's on, would you please, do you have Steve?
Hello?
Yeah,
We
Steve.
can hear you.
When the question was when somebody from the VA that has VA benefits comes here, do we service the VA directly or just how does that?
You broke up during the question or I was making noise. So can you restate that question, please?
Or when a member of the community comes here with VA benefits, how does that work as far as payment to the VA? Do we submit our bill to the VA and they pay it?
In the circumstances where they're going to be responsible for the payment of the claim. Yes.
Okay, so we'll bill the VA.
You bill the
That's what it sounds like, yeah. And I believe that the VA made it easier for veterans probably a couple, 3 years ago to get care when they're too far away from a veterans, so they can go anywhere they want. And there's a reimbursement structure.
Okay, so just comes through like with the regular insurance and you will bill. If
That's
they
fine.
don't have a copay.
Right, well, the copay, gosh, I'm gonna get myself in trouble here, Steve. So if a veteran comes here, they can seek care here, correct?
Depends. Because there's certain things that the VA wants to be treated at a VA facility, regardless of the distance. So
Okay,
there are
so-
some things, depending on the nature of the treatment they're receiving, if it's related to service or whatever it might be, there's like a big decision tree.
Okay.
So probably the best thing to do would be suggest that the patient reach out to us. And we would just have to handle the case based upon the circumstances. There's not like a broad brush, unfortunately, that we can paint for this. But the short answer is yes.
Steve,
People
is it
covered by VA can come to the facility, but there are certain forms of treatment that the VA wants to have taken care of
At their
at
sites.
a VA facility.
Okay.
So just like a general visit or something like that.
Yeah, it'd be really good for her to come here so that we can define what services we can provide and build the VA and which services they want.
Case by case.
Kind of, yeah, kind of what we're doing. I would like to actually, Steve, since we're talking about that a little bit, I would actually like to, because I get this inquiry more than you know. I'd like to get an understanding from the VA if we can get their list of things that they allow and things that they require them go to a veterans, because this question does come up quite a lot, actually. So,
Steve?
You have a lot of patients that come in that's with the VA.
yes, ma'am.
Yeah. Steve, is it usually the urgent or emergent services are covered by the VA though?
Yes.
Okay. Well, still, maybe a takeaway is to get that list.
Oh, I'm sorry, Shelley. When you say covered by the VA, everything's covered by the VA. It's where they want to have the treatment take place and where they'll pay, who they'll
Right.
pay for the services provided. So yes.
Right, because the patient could incur a shared cost.
Yeah.
For services that they wanted.
Yep.
The patients to receive.
So let's go back to that, Steve. I would like to know that list of things that the VA requires the veterans to go to their sites. I would like to know that so that I have more knowledge as well. So it'd be great. Good question.
Case all ahead of time.
Good question.
Yeah, very good question, Shirley. Hopefully we'll have more information at our next meeting then on this
Yes.
topic. Other questions, comments? Okay, and with that, we will move on to number 8, approval of the regular board meeting minutes. If board members have a chance to review those, if I have any questions, comments, or a motion to approve them,
I approve.
we'll move.
Second.
Second, thank you. All in favor, Sherry,
Yes.
Shelley?
Aye.
And I'll vote aye. Thank you. Okay, next up, medical staff report. Approval is requested for reappointment for medical staff, initial appointment of medical staff, and reappointment for allied health practitioners. I think that NA needs to go away from there. There's listed below. Do I have a motion to approve the medical staff appointments as listed?
I move approval.
Thank you, Jerry. Do I have a second?
My second?
Thank you, Shelley. All in favor, Shelley?
Aye.
Jerry?
Yes.
And I'll vote aye. Okay, next up, policies and procedures. I appreciated that, I think there's only one that didn't have, I couldn't tell what the track changes were, but of the others I could easily. I don't know if any of the board members have any questions or comments on the policies and procedures.
How could you tell? Well, I couldn't open the actual stuff, but,
The track changes ones?
yeah, I couldn't
Um,
open those.
Oh, yeah, because when I open the Word documents, if you use Word, then you can see them. But you have to use Word in order to see them.
Have Word, but I think that's an issue. I
You have
don't
to
know
open
the
it
issue
in
is.
Word.
Yeah,
Yeah.
Yeah.
we'll work on that.
Okay,
Once again, I think we're trying to get that online.
yeah,
I think we've made a decision, Judy, on the software. So rather than having to just send it, we just log in and we can see all the changes and stuff. We have made a decision on the software that we're gonna use.
Okay, perfect, good.
So in the future, we'll
That'll
make
make it
that
a
a
lot
lot
easier.
easier.
Mhm.
okay.
It's been an ongoing
Battle. huh?
Yeah,
trial and tribulation for a long time, yeah.
I do like how in the minutes, the previous minute, report for P and Ps, I do like how there's the comment column
mhm,
where it says, if
Made
it migrated, if it was inserted into another policy and no need
Yes.
for it. That was easy. I like that.
I agree. That made it a lot easier.
Yeah.
To follow what was happening with them.
Yeah. So are these the only ones that today that need to be? Yeah, there's not a whole lot, right?
Well, we're rescinding,
Well, there's all
we're
of
rescinding
these.
all of these ones, and then we are approving. these
Okay,
ones. Yeah,
okay, all right.
so with that, do I have a motion to approve as presented?
I couldn't open it up, so.
Yeah,
Um,
I move approval.
do I have a second?
I second, on trust.
Okay, all in favor? Shelley?
Trust.
Yeah.
Aye.
And I'll vote aye. Thank you.
Trust that we're doing the right
Trust.
policies.
Right.
Yes.
That's right.
All right, next up is number 11, agreement for licensed timber operator services, change order 0001.
So when the original when the original contract went out for our timber operators, we had requirements by NEPA to do cleaning. We had to clean the equipment. And that was not in the original proposal. They were able to utilize Collins Pine Professional Cleaning. They have a cleaning, equipment cleaning over at the mill. Well, this is a change order to clean all their equipment as a NEPA guideline. It's a NEPA guideline. They can't get on the property until they've been cleaned and certified. So this was an add change to the original thing. We already knew it's coming. This is the original. This is the official one, and I'd like to get board approval for this change order.
That's pretty expensive, 38,000.
It is. Well, it's the equipment.
It's a
There's
lot.
also there's
A lot of work involved. with
there's
it,
a
right?
lot of stuff involved, a lot of paperwork. You have to file everything. So there's a lot to it. It was expensive,
Okay.
but they're big pieces of equipment too. And
Sure.
they have to
Thank God
clean,
Collins had the
clean.
facility.
What's that?
I say it's good to Collins had the facility.
Yeah.
God
Yes.
knows
It would have been a lot more.
Cost more.
Yeah. They would have actually had to truck them out to clean them and then truck them in. The bottom line, and I understand the logic behind this is that, they don't want anything that's been sitting in a different area of the state, bringing
That makes sense. Total sense.
bringing dirt and seeds and stuff,
Bugs.
bugs. Interestingly enough, all the equipment is from our area. So,
Yeah,
but it still needs to be
Still
cleaned and
unfair.
certified. Yeah,
Sure.
it was expensive. Everything's,
Yeah. I know.
it's all prevailing, so.
okay,
So I move approval of change order 0001.
I second.
thank you. All in
Thank
favor?
you.
Shelley?
Right.
Sherry?
Aye.
And I'll vote aye. Thank you.
Okay.
Okay, next up, new critical access hospital board updates +2 medical equipment reports, Donna. And if either of you want to see them, those are the medical equipment reports. Donna,
Yeah, sure.
Alrighty, so should I proceed?
yes,
Yes.
please, thank you.
Alrighty. EMS helicopter, we're referring to the summary report first. The EMS landing site, no update from the last meeting, just working on getting the official approval on that from Division of Aeronautics. But don't anticipate any concerns there. Harvest plan, as everyone knows, the blue herons have flown and timber harvest has begun. As was just indicated, all the cleaning of the equipment occurred and Sean was able to certify that cleaning so that we could get moving forward with the trucks on site. About as of 2 days ago, they thought they were about 75% done and with the tree cutting, and then they'll follow through behind with the stump removal. We had a meeting out at site on Wednesday to include the earthwork observation folks who will also be on site when those stumps are being removed, to make sure that they are fully aware of what's being left behind and how those holes are being addressed, to make sure that ultimately they, as the entity that will certify the pad and make sure everything is properly compacted before the site is constructed, they'll be able to carry forward anything that needs to be done as a result of the timber removal during the grading of the actual construction site once we start construction. So all that is just to make sure that we have consistency across with the same entity, observing the whole thing, able to certify and be responsible for that. Expect the contract duration for this work was for 5 weeks, is for 5 weeks, and so hopefully we can expedite that, but no word yet as to whether no official word yet as to whether that it can be expedited, acknowledging that we started on 10/18. Wildwood easement, no update. Financing for the USDA loan. We're working through the letter of conditions provided by USDA and just making sure that we fully understand all the implications and getting all our questions answered on that letter of conditions. So working through that with them and our finance folks. Other funding, we do have a proposal. I can't remember if I brought this to you guys last time. We do have the proposal from BKF to do grant prospecting at a cost of $6,000. We're reviewing that and determining whether that wants to be part of the process, part of the effort to for the full funding of the project.
And what was the scope included in that proposal?
So that is to do a grant, like a review of all the available grants that would be applicable to our project, and provide that summary and guidance to the facility. That does not include the actual grant writing that would then proceed from there.
Grant
So that
management.
would be, oh, go ahead.
Basically just
It's just. to
say,
go out
here's a
and
list
search.
of
Yeah,
available grants that you might qualify.
That's it.
Okay, got it.
Thank you.
Alrighty. Other funding. Donor packets are almost complete as of time of this report writing. I don't know if we have any further updates there. But they're underway and we'll be going out, and no update on Senate Bill 395 from our September meeting. No updates on schedule. No updates on budget. Things are steady there. Where as we indicated at the last couple board meetings, we will be bringing the GMP to the board for review in November, and so I'll get all that updated for the budget, within the budget, if there are any updates that need to occur there at that time. Design, for the site, we do have agreement from Peninsula Fire to review the site plans for fire control and access. The new chief starts on the 1st of November and has committed to doing that review for this project. Additionally, there have been some updates just on incorporating landscaping, incorporating the outside generators, the helipad, all that information into the site drawings, and those have gone back to county CPUD for wet utilities, and now we'll also go to Penn Fire for that review. So that's a revision to the already approved site plan. So we have a basis of an approval, and then we'll modify any updates based on, or we've modified with updates, and that's being re-reviewed by all the entities listed. We did get comments back from HCI on our shell and core, so that's our increment 1 and 2 that went to HCI in July, and so the team is reviewing those comments and aiming to resubmit mid-November. And in parallel, interiors design we got to a 95% set mid-October, and that's what's being used to develop that GMP. And the 100% CDs construction documents are on track to submit to HCI on November 2nd.
And what kind of feedback did we get?
I'm still in the process of reviewing that, frankly. I haven't heard any huge red flags being raised yet, but I personally am in the process of still reviewing that.
Okay, thank you, Donna.
Medical equipment. So as requested at the 9/28 board meeting, included within the packet is the updated list of medical equipment. So that gives you not only the items, but the associated costs, and noting that the equipment went down by almost $1 million from from July till now, and so they've really been able to skinny up the costs with getting actual quotes, pinning down, well, first pinning down vendors and then getting actual quotes. And so that has really helped to refine the list and associated budget. I did want to state here, I'm looking to better understand what the looking for guidance from the board on approvals for that, for proceeding with purchase. If we need to just get approval for the 5.4 and manage to that, or if there's some more granular approvals that need to be achieved throughout the procurement process.
Well, let me ask a couple questions on that, Donna. Well, I had a question. I don't remember which of these lists it was in, but I did see in here that we're documenting stuff that's existing that we're gonna be using. I noticed that. That was very helpful. There was a piece of lab equipment though somewhere in here that had a notation that said it was future. And I think it said something about Monday saying that it would be a future item, but I think it's still in the bottom line on this. So I was just trying to understand that.
Okay, I'll have to look into that and report back.
I don't remember which page it was on, but it must have been on the other no, because in here, new, existing, future, info, leased, and capital. And then I was curious about, I saw that we were going to be leasing our medication dispensers, and I wondered if that was a normal thing. Is that usual?
So the Pyxis are all leased equipment. So it's, we could move over. I think what likely will happen is most will get returned and some will get supplemented at the new facility. But they're all on lease, both now and at the future facility.
Thank you. And I guess on that, did I miss anything that, was there anything else in here that we're planning on leasing besides those dispensers?
Yes. So Donna, that would be the discussion about the Stryker surgical equipment that we're still working on.
Yes.
So we've met and we've had a communication with Stryker regarding a lot of the surgical equipment that is in our existing surgery suite probably will not last till 2026. So we were going over what exactly that equipment is and how it could either be purchased now or could we lease the equipment now, and then with the option to buy later and would lock in the current prices or the 2024 prices. So when we purchase it, we're purchasing it at today's prices, okay, 2 years. So we haven't gotten those final estimates yet, but we hope to be able to present those to you guys to see, one, if we purchased it outright now, the cost of this equipment would be approximately $160,000, possibly a little bit more.
Okay.
And so we're asking, what if we just leased it for now? And what would that look like? So we hope to have those figures for you soon.
Okay, so do you think we'll be able to have that for our November meeting? And when we're talking about the GMP and all the rest of that stuff, and so we can understand what our capital purchase, if there's anything even beyond that, what our initial capital purchase needs to be before we actually are over there?
Yes.
Okay, thank you. That'd be very helpful. Okay. And I think, Steve, did you want to have a question you wanted to?
Yeah, is this the project manager?
Yes.
Yes.
Okay, is that a private entity? Okay.
Yes.
I was just curious, you mentioned something about CPUD there and plan approval.
Yeah.
Well, why didn't CPUD do plan approval? They're right here.
We submitted the plan approval. It was taken on by CPUD. They were using a third party because neither the fire chief or anybody from CPUD can do fire plan review, site review. So they got a third party. And then I received an email from the general manager of CPUD saying that they are going to halt all activity on the site review as they are pending shutdown. So knowing that I had last available date, to get this done through HCI, which is the, OSHPD at the state, the plan review had to go forward for our submittal to HCI. And since the CPUD general manager felt that they weren't going to do that, even though they are still and continue to be the responsible party, I spoke with HCI directly to find out if I could have a different entity that's in the basin do the work. And they said yes. So I just went to Penn Fire and they decided to do site plan for us.
Good question.
Interesting.
Yeah.
Now, when did that go to CPUD?
Oh, it was a long time ago. We started, when did we submit to the site plan for review? Donna, was it close? Was it right around July?
May, I
July.
believe.
May, June?
I think it was May.
Yeah, in May. What's that?
We could not do it.
No, you could do it. No, you could do it with a consultant. A consultant was doing it.
Okay, so we would have to hire a consultant.
You did hire a consultant.
We did hire.
Yeah, you had a person doing it. They were doing the review. They did initial review. They submitted some comments. And then I received an email from the CPUD general manager that they will stop all that activity
That was last month, right?
about a month and a half ago. So
Yeah, and without that, we can't move forward with our project.
I understand.
Penn Fire is happy to do it.
Wow. Thank you.
Mhm.
Okay, I guess back to Donna's question about the equipment approvals. How do we think we should handle that? And Rich, you can chime in here. You just can't vote.
Yeah, I think one of the key things is to determine the question we were just discussing of, can we lease some of the equipment rather than purchase it outright
Mhm.
before we know for sure? Because if we determine we're not gonna do that,
Mhm.
that changes some of the figures.
Those, yeah.
Well, leasing's always good too, because then they cover the maintenance of it,
Right,
Yeah.
and those warranties.
plus it gives you a chance to see if you like the equipment, maybe it's something that
Yeah.
doesn't do what you thought
Right.
it would.
Donna, were you looking for the board to approve the 5.4, which was in the budget?
No, I know I didn't put that on the list for approval. I just am looking for guidance on so these lists were requested at last month's board of directors meeting, and so it was not clear to me how we, knowing that we need to get a general approval from the board for anything over the 25,000, and how we need to manage this equipment line item when if it's reasonable to look at a bottom line and allow the team to manage within that bottom line the purchases. Does that make sense? So in concept right now, and then knowing that whatever is discussed in concept gets brought back to the board for official approval.
I'm comfortable with that approach. And I have to say, I very much appreciated seeing these because going through this shows how much work this whole
The
team
detail.
has been going through in order to make this happen. So,
Yes.
I mean, I knew it was big, but I was astounded when I looked through it.
And I can tell you that on top of that, Jerry, selection was not made based upon current state. Selection for a lot of this was based upon future program,
Mhm.
being able to make sure that we have the equipment for a pretty heavy capital cost. That all of the equipment going forward either has an upgrade path
Mhm.
without having to change it out. So it has an upgrade path into the future of what we consider to be programmatic in the next 6-7 years. So we cast this thing forward as far as we could as it relates to what we might be doing here. We may not have purchased that module, but it's capable of upgrading without
Right.
tearing it out.
Perfect.
So there's a
Right.
lot of due diligence put into this for current state, 3 years from now, future state, and then 8 years from now, future state.
That's awesome.
Yeah, I think this
Kudos.
is incredible. It
Yeah,
really is.
so
It
much
really,
work.
really is.
Yeah.
So thank you, everyone who's involved.
Yeah.
Everybody.
And thank
Yeah. I have a question with the equipment that is being leased. Is there usually or sometimes at least a purchase? When you
Yes.
lease it for a certain amount of months or time, at that point it's considered purchase.
Yes.
Okay.
You know, and we also brought up to the equipment manufacturer or the equipment planner evergreen clauses. You know, where we purchase this, then we get certain types of upgrades that are not programmatic upgrades for free forever. I mean, and I did, Judy, you know, did we ever hear anything, Donna, that Casey was talking about evergreen clauses for some of the stuff?
I'd have to follow up with him on that.
I know we requested, I don't remember if we got it back, but that was one of our requests is evergreen.
Yeah,
So
yeah.
we'll see what they come back with.
So I think this is a helpful starting point for me. I do think that our staff need to have the flexibility to change some things out if, you know, a vendor's no longer in existence or something like that. So, I think as long as we're sticking to our budget for these items, then I'm comfortable with that approach. Do you agree?
Yes. Yeah.
And if I may just address that for a moment, I think that the other piece that they were looking at while they're making selection was the efficacy of the company. And if it is a peripheral company or if it's a more mainstream,
Okay.
I don't think anything we chose is peripheral, right? A company from, you know, somebody's barn in Arkansas or something, it's not that. These are all viable companies with good market share. And
The ability to service this.
correct, that was another one, servicing this
Yes.
location, parts availability, servicing this location. Those types of things were all considered.
Okay. Does that help, Donna, with what you were asking?
It does. So then I would propose that I bring back to within the November Board of Directors meeting for approval, the bottom line for this with the ability to manage within that dollar amount. Do I need to further before doing that, further investigate the leasing option? Because right now I'm as we're speaking here, I'm going through, and the only leased items other than the potential for doing the lease that Judy was describing for the Stryker equipment prior to the new facility. Outside of that, the only leased equipment is the Pyxis. And so do I need to, are we looking to further investigate that possibility to get down this capital
I
cost?
think we should. That way we have a better understanding of what our ongoing costs are gonna be versus our upfront costs.
If I could maybe pull an exception out of that, you know, but maybe not the imaging equipment. You know, I think that the lease sometimes plays out, but I find that the CapEx, you get a better price. And that's what, so we've been able to drive for the imaging equipment, we've been able to drive it down 1.2 million.
Yeah,
Because
no,
we're
I wasn't
so get
asking to
the
have
flexibility
option
of
for everything.
choosing whether or not something is smarter to lease it right now.
Right.
So that's the
Right.
flexibility we're asking for internally to get within that dollar amount.
And
Yeah.
this is truly for the equipment that, again, we need to purchase or lease prior to 2026. So,
Yeah.
and Stryker was actually the one who brought up the potential for a lease option because they understand how we're strapped for cash flow during this period where we have a lot of financial outlay.
Yes.
And so they were very thoughtful in that regard. So, but again, we don't have the figures for you yet, but we should have them for you very soon.
Thank
Are
you.
all the beds record?
This is only for, surgical, equipment, for endosuite, surgical suite, things that will eventually move from our current parts to the bones.
Okay.
And then, the other, pieces of equipment that we'll need, we will need some, new ER rooms prior, probably this year.
Okay.
That we would just purchase 2 of the 5 or 6 we have planned for the ER, and then we just roll over there. And so that's not a huge outlay. But, and then the other is the potential of the Cupid lab equipment that you saw on there. And so.
That's a possible,
That's a still possible.
for here, for our current
Yeah.
state, okay.
Do we lease the patient beds? No,
Yeah, no wrong.
doesn't make any sense no.
No, it actually, they're not that expensive and there's not that many patients laying in them and they have an extended service contract. And so they're all within the last year and a half brand new.
Okay,
Okay, they're beautiful. Yeah.
so they have the automatic weights.
Yep.
Nice.
Yeah, we did a big replacement.
Mhm.
All of our beds were quite aged. So we did a replacement over the last 2 years of all of our inpatient beds. And they're nice.
For the LTs, for the long-term care unit,
Long-term
that
we
new.
do.
we have the flotation.
We
Beds.
we have some airflow mattresses.
Oh, nice, okay.
That we can switch out as needed, and some scoop mattresses for safety. We're in good shape there, but we will be purchasing all new beds for the new long-term care. But we should be able to make it with what we have right now, no problem.
Okay,
Yeah. Definitely.
all right. No, I saw that chair, hence the Kualu or whatever it is.
Right.
Are those leased or are all those
So that's actually
beautiful?
just, we had our furniture vendor here last week. Unfortunately, it's the same day that the state arrived. So they brought a sample for us and then they just left it here for us to try out. But that is, the company that they did most of their much.
Shirley, I think you should sit there to let us know if they're gonna be comfortable. Don't like it.
No, I like to sit more upright than.
So they're gonna give us, we're just trying them out. Obviously, it's not the cloth either. They're gonna be more.
Yeah, that's what you were
Yeah.
asking.
I was thinking, that's a lot of cleaning.
Having had experience with what public use does to furniture.
Oh, boy,
Yeah.
well, especially in a hospital, yeah, so.
No, Florence would kill me if I did that.
Yeah.
Yeah, the furniture vendor has made it very clear that everything they're planning on specifying is a wipeable material.
Viable, yeah.
Good.
So we're playing with different types and styles and, you know, if they sit up or sit back or put your feet up or make your coffee for you, but, yeah, we're still working on those.
Yes, and that's out, and just to be clear, that's outside of this equipment, so it's a different line item for the
Okay.
furniture. So it's probably, you know, we might want to think about this as a potential model, so to speak, of purchasing like equipment this way. We're approving a bottom line. Similarly, the board approved at a previous meeting the bottom line for the furniture that we could contract with the furniture dealer for. So, you know, just kind of thinking about all those kind of lump sums and and counting on the project team to manage to those, similar to what we're asking for the equipment.
That makes sense, Donna, but I would like to do the same thing where we have the opportunity to review what it is that is being
Absolutely.
selected.
Yep, you got it.
Thank you.
Definitely.
Just because, you know, what if that was the chair?
Well, that is one of the chairs. I mean, minus the fabric type.
Right,
but-
right. Okay,
Yeah.
thank you.
Alrighty, and then just finishing up on equipment. So again, the excess from the savings on that equipment line item went back into the project contingency. So basically I track the contingency log pluses and minuses, and this was a plus to the contingency. And then right now that contingency stands at a little less than 4 million.
And good job
So
to doing that too.
No kidding.
We're looking for every penny.
Yes.
Alrighty, so I kind of jumped ahead on that next one. I had already let you know that 95% drawing set's being bid, and we're bringing to planning on bringing the GMP to the board next month. And then lastly, the NTP 3 that the board approved previously is going through back and forth approvals. The legal is incorporating things like the final letter of conditions from USDA, and so we're adding in some other things to that notice to proceed, just as a legal amendment to the contract. And so that's why that's not final, but it is being finalized.
Great, thank you.
Any other questions?
Anybody have any other questions for Donna? Questions, comments?
Thank you.
Thank you, Donna. Appreciate
Thank
it.
you. Thank you.
Thanks, Donna.
All right, next up, Sean, CEO report.
Sure, my CEO reports get smaller and smaller because we talk about so many things that are relevant. So I will just talk about new hospital build efforts. Wait a minute. But
Did
That was the bird
do
tree.
nest?
I think the nest got decimated on impact, but
Darn it.
I know we were gonna try to save it, so thank you for playing that. That was our. The heron tree came down officially today.
Yeah, save that file.
So the licensed timber operators out there, they're working, it's great. Obviously, it's changing the look of the place, but you can start to get a sense of how flat that property is. So it's really great for building. It's really gonna be amazing when they start to skid it out. And it really starts to prepare for grading. So the bird's gone, the big tree where the bird was is gone. So we're gonna continue with that. We'll continue to work through our specifications on a USD letter of condition.
Now, Sean, on that, we had talked about possibly seeing if we wanted to see if an outside party would track that for us or help us with the letter of conditions. Did we look into that?
No, I think Steve, we're comfortable tracking the ins and outs of the LOC, correct?
We're still trying to get them finalized, Jerry. So once we get to that point, we can determine what our needs are.
To keep us honest on it.
Fair enough. I just
Still
want
on
to make
the
sure, I just want to make sure it's not going to become too much of a burden on staff that
Right.
have.
And
other
or,
things to do.
or it's assigned to somebody to track the LOC or things like that, but we'll talk about that when they're set.
Okay.
And we have to track and we have to report.
Okay, thank you.
Okay. Final approvals for design is ongoing. It's really now, as it relates to fire suppression and IT. There's a lot of, the nitty gritty around information technology is happening and some fire suppression pieces. So we're getting into the very, very final portions of design. Like I think Donna said it was 95% baked. So
Missed that last
Yeah,
one.
95 as of middle of October and 100% as of next week.
yeah, so we're working really hard to get this completely buttoned up. And then we can get that GMP. So existing hospital campus, we have finalized the design of the boneyard. We call it the boneyard. That's for those who haven't been around. It's the space upstairs that collected all of our junk that we cleared out, and we are looking at building it out and doing some improvements or tenant improvements out there to bring the finance team closer to the HIM team upstairs and bring this into more of the bottom part is more clinical. We received a final drawing today. I'm waiting for some feedback from some of the staff, and then we'll take it to bid to see exactly how much this infill project might cost us. Once again, I'm not looking to do it right away. We have to really pay attention to our finances, especially as we start to move into the next 6 months or before funding begins. So I am going to press forward though with taking it to bid. So we have, it looks like final drawings. And I'll just update the board as we go, but we may take it to bid, see where we are to build that out. As you know, 869 Senate bill, the legislative updates, the seismic was shelved until next cycle. It wasn't killed. It was literally put to bed or tabled until the next legislative cycle. And 869, for those who don't know, was to get two things: a reprieve on the date for the Senate seismic bill, Senate Bill 1953 of 1996, to either kick the can down the road one more time, and we talked about this. It's to give other organizations an opportunity of finding out what they're going to do. We have been very, very proactive in this and are going to be moving down this. So the seismic piece goes away when that's built. So we're out of the woods, but there's still a lot of legislation being pushed to kick the can down the road, which is only to double the cost of building a hospital in 10 years. But it also had a funding piece to it. I can tell you that 869 fell flat when it came to appropriations. They flat out said that there is no money that's going to be given, from what I can read. So they're going to they're going to reinsert it next year and see what happens. We've been talking about Senate Bill 525 forever. It is signed. For those of you who don't know, that is the $25 an hour minimum wage for healthcare workers. It was signed by the governor.
Last day.
Last day, last minute. This is a very union push thing. So no matter what you do, and then one, even in doctor's offices, it's $25 minimum wage. The rural hospitals and critical access hospitals have been given a ramp into this thing, so it's starting at 18 in
Next
June of
year.
2024 with a 3.5% annual until we get to 25. So, but it's not just the minimum wage, as you know, it creates compression.
Mhm.
So it compresses, we have to keep a wedge compression all the way up the chain. So suffice to say, this is really, really bad for healthcare in California. I mean, you can't underestimate how bad this is for California. Cost for healthcare will go up. It's like anything else. If the cost of food goes up, cost of fast food goes up. It all goes up. It's going to continue to go up. The worrisome piece of this to the board that I think you need to know is that although it's a critical access hospital, Banner being a large organization, being a 26 hospital organization out of Susanville, did not get the 18. They have to go to 21 immediately, which creates a bit of a vacuum concern for us for the minimum wage. So they have to go to 21. So while we're paying 18 for minimum wage, they'll be at 21. And we're a little concerned about maybe the vacuum of some of our staff going over to Susanville. But we'll see how that goes. And it's about culture and environment, what it's like to work
Well,
somewhere,
the additional cost of fuel to
the
get
fuel
there.
to get there. So
And the
I think-
And the
danger.
prisons.
Yeah.
closing.
Absolutely.
we're gonna really be watching that to see if we start get some leakage in our staff over to Susanville. Not that we're gonna suddenly go to 21. We simply can't. That'd be fiscally irresponsible. But yeah, we're gonna be watching that very carefully. A little concerning. Yes, ma'am.
Will that apply like with the fire department with their EMT?
No. It's considered, no, the EMTs were not involved. They were exempted from the same bill. I bet you they'll have their own coming up though soon. You watch.
Probably.
They might have
What's that?
I said, bite your tongue on that one.
Oh, I know, but I just know it's gonna happen because they're in a shortage too. So.
I had a question about the AV, the seismic.
Yeah.
So. The utilization of the current hospital and ER and all of that. How will this or could this impact the utilization of that building?
Absolutely.
For future.
Absolutely. If being able to use it as an acute care or as an OSHPD 1 level facility if they kick the can down the road, we could potentially continue to use that as is for a period of time for other things that are required OSHPD 1 level type facilities.
Mhm.
So yeah, it could affect it. It could affect it, definitely. About how we repurpose it.
Right. Could patients still be seen in something that would not pass that or meet that requirement?
I'm sorry.
Could a patient or a client, could we still have an outpatient office?
Yeah,
there?
sure. So that's a
Some
lower
sorts.
OSHPD level.
Yeah,
It would still need some retrofitting. I think that if we start looking at restructuring that, there's ADA requirements that we would have to meet right now where we have this sort of reprieve. But if we start touching it
Mhm.
for retrofit or anything like that, then the ADA is going to come in play. And
okay,
we have a lot of ADA things that are not compliant over there, like bathroom sizes.
yeah, yeah.
Right? So I'm a little, yes, we can continue to use it, but if we start to do a lot of TIs over there, we have to really be careful how we do that.
Okay,
Because it can become cost prohibitive in a hurry with
Yeah.
ADA and asbestos.
And
Yeah.
and exploring those options, I think was something you and Ken were gonna start working on, right? Yeah,
So,
Start looking
Yeah.
at reuse, potential
Yeah.
reuse.
well, we're still incidentally, and we're talking about maybe putting out a Survey Monkey as we start to, growth strategy and everything is campus wide. It's not just the new campus or the new hospital in this facility. Repurposing that, there's been a lot of things that have shoved around. I think that maybe a Survey Monkey to the community is how would you like to see it? And then weighing I've had the VA instance, they've been talking to me for 2-3 years that they would like that emergency room as a clinic for VA. They've been talking to me about that for a while now, and I would like to entertain that. Where they could do VA work here without, those kinds of things. So we really have to talk about how we repurpose it, and this is going to give us a little reprieve for what we can do.
thank you.
Yeah, sure. Sorry, long way around the barn on that.
I know, that's okay, thank you.
COO recruitment. So we had, it said 90 applicants with the sign of this. We actually had over 100 applicants for our COO position. We ultimately went through to about 15 CVs that were additionally vetted. I ended up with 7. I did conducted lots and lots of virtual interviews last week. I'm down to 3 that I think should be vetted more. So we are now in the process of notifying the 3. And those are going to be a full day, face-to-face, 2 interviews. It's going to be the full tour, discussion, and panel interviews. And some of the board members we haven't selected yet, but we would like to see board members on the last one. A couple of selected board members. So if you'd like to be on those, please put your hand up and say me.
Maybe our 2 newest board members want to do it.
Sure.
If you'd like to be on the interview, we'd love.
Sure.
Sound
Sure.
good?
Mhm.
So it's going to be an all-day thing for all 3. And then what I'd like to do is make a selection within the next couple of weeks with a placement by the 15th of December.
And for context, the purpose of hiring a COO at this point in time, we've talked about succession planning and about you hoping to retire
Hoping
at some
to.
point after our new hospital is up and running.
Yeah, it is a succession plan. But they're also going to be immediately taking over a lot of the block and tackle operations. The things that
Traditionally would have been under a clinic manager that we don't currently have.
and are traditionally under a COO. They do a lot of the tactical. Yeah, and I'll go to strategy, build, philanthropy, some policy things that really should be paid attention to. But this is the block and tackle of healthcare. This is the operations, and we're talking every bit of the operations, analytics, programmatic growth, based upon the strategy. The strategy we develop together, but they implement the strategy. That's their job. Hardest job in healthcare. Not
You've got a hard job over there.
it's tough, but so we
You've
should
got a
be
hard
down
job.
to we're down to our final 3, and we'd like to invite them up and grill them a
Yep,
little bit.
great.
Great.
Sure.
Cerner conversion, we continue to tweak Cerner, focusing on training and adoption as they should. We've had other conversations and other meetings where we have some workflow challenges and some retraining on some compliance challenges. I've been talking to Brian on a regular basis about how we go about ensuring that we are capturing what is being done in this facility and that electronic health record at the time in real time. So we are very aware of it. We're aware of the implications to finance and the accounts receivable and coding and things to that effect. So I just want the board to know that we are continually tweaking this and working towards that nice smooth process. And frankly, it's been 6 months. It takes about 9 months to a year to really fully bake it out and get it done, but we're doing good. I'm pleased with where we are. Mid-level recruitment, physician and mid-level recruitment. We've interviewed a couple of mid-levels. We've got another one tomorrow. We had one today. We interviewed extremely well virtually. We interviewed a potential ER candidate, interviewed extremely well. This was Dr. Nielsen was with us, for about an hour and a half. So we are getting the interesting thing is we're starting, I don't know why, I can't tell you why, but we're starting to get some really interesting inbounds. Physicians and mid-levels that are coming here and are showing a true interest in us, and they're of higher quality. I think things have settled down after COVID a little bit, and people have made decisions about where they want to go, what they want their life to be like. So we've had some really, really good submissions. I just got a submission today, in fact, just about 15 minutes ago, from a Reno family practice doctor who has 5 stars on their doc. I mean,
Wow.
they're 4 or 5 stars. They've been in practice a long time. They know Chester, Lake Elsinore very well. And they put their hat in the ring for another family medicine position. So
Are they finding out about our new hospital?
they
And
are.
that's how why they're coming? I was
It is
wondering
part of
why.
our recruitment is that they send the video. And so maybe that could be part of it. So we've got some things, we will continue that.
That is exciting.
It is exciting. It's exciting to talk to people that are excited about coming here and making it a career. So it's great. Dr. Tom Greeley started last Monday, basically orientation. Tom Greeley, for those of you who don't know him, he's a retired family practice practitioner from John Muir Health System, family medicine. In fact, he did a lot of proctoring for a lot of residents. So he, I've known Tom for a long time. Tom, apparently he's a little bit bored, so he's going to be coming on board. He's starting to accept patients. He'll only be working 4 days a month, Mondays. But that's a position that's the physician's now taking patients. So he's on med staff, he's ready to go. So he'll start accepting
Which
patients.
office will he be
He'll be
in?
in Dr. Russo's office, because Dr. Russo doesn't work Monday.
Okay, perfect.
So we'll stagger him and he'll have that office on Monday. I think he's gonna be an excellent addition. Got a great personality and I respect his science as well. I think he's a good scientist as well.
I think ideally from a patient perspective, it's optimal to have. For a patient to have one physician,
Yes,
you know, for
yes,
continuity.
definitely.
So is that our vision? to move
Yes.
Toward that? Okay.
Yes, in fact, we've just spoken, we're speaking to the walk-in clinic that when they come in and a person needs more of a chronic follow-up,
Mhm.
that we start referring inbound to, since we have practitioners that are now accepting new patients, let's get them established
Okay,
for that continuity of care.
all right.
So we're starting to do a lot of things where we're driving into the continuity of care, long-term, good management,
Mhm.
and leaving that walk-in open for the sniffles or something that happened and I couldn't get an appointment.
Do we have any internal meds at all?
No, we had internal meds submitted to us. The problem with internal medicine is generally they don't do a lot of procedural work. So, if they stitches and and punch biopsies and things that family doctors
Mhm.
tend to do, they focus a little bit more on older, folks, which is fine, because look
Which
at.
is
look at
what we
me.
need.
Yeah.
Yeah, our aging population
But
here.
while they're good with that, they lack some of the procedural stuff that a lot of family medicine doctors do. I just find
Yeah.
them to be more rounded. I won't say no to an internal medicine doctor. What's that?
I was gonna ask for a specialty in geriatrics.
A gerontologist,
Yeah.
wouldn't that be nice, right?
Yeah.
It would
Yeah.
around here.
So I'm not against internal medicine,
Yeah.
as long as they can say, hey, I've done procedure work and I'm comfortable with all of that. Because they've been
I'd say
submitted.
that most of the people that we're interviewing, I mean, the population of America, regardless of where
It's older.
they're dealing with gerontology. no matter
Yeah,
Where, so it's not a different mix here, so.
yeah.
they
I
all
think
have-
it's just nice for people that have chronic conditions, multiple chronic
To be
conditions for internal med,
Yeah,
you know,
yeah.
but. I
Once
get
again, I'm
it.
not
I
against
get
it.
it.
I get them submitted. A lot of them are acting as hospitalists these days.
Yes.
A lot of internal medicine doctors have
Yes.
stopped practice and
I
gone into
know.
hospitalist practice,
I know.
and they don't want to leave it, so. Good. Any questions on my report before I go on to this next little piece of paper?
Oh,
So we're getting you cannot believe how much this organization spends on copy paper.
Oh, really?
We were gonna do 5
That's
of
why
those.
she only did 2 slides.
Glad you didn't.
We were gonna do 5 of those
Oh, no.
for every board member plus me, that's 6. So I just think
A total of 8, actually.
a total of 8.
If I gotta put it in the.
Reams
Yeah.
and reams and reams and reams and cases of paper.
Yeah,
So when you take a look at that stuff, it is expensive.
mhm.
It's not cheap, let alone the toner and everything else that goes into copying. So this is just a heads up that we're very interested in new ways of doing things. Maybe something like this where it's huge. We have a couple on the table. Electronically would be good, but I'm looking for the board's opinion on just trying to cut back on the amount of paper that we copy
no, I agree.
and
And
print.
as a matter of fact, I actually was just talking with John Kennedy earlier today about the Civic Assist that they use for the city of Portola. So it helps you create the agendas, it helps you create the minutes. I think you would be very, very happy with what it sounds like it can do. And I was gonna explore that further with Shelley, and hopefully we can come
Little
to the
iPads are
board
great.
for a recommendation.
Little iPads are great. Where board members sit down with a little iPad in front of
iPads.
them, all the docs are loaded and boom.
I could bring mine.
Yes.
So if I need to be able to open up the documents.
Yeah.
Right.
Well, that's, yeah.
I recognize that problem.
So I would just like the board to say, guys, Sean and Deborah, and everybody, let's look into creative ways to provide you the documents that you need in a way that you can read them. They're available to the community online.
Or if they
But
want, me,
there's-
we'll print it for them.
Or print maybe a couple copies like this, but we are just going through trees and trees and trees, and where we're dropping trees, those aren't good paper trees, so.
Well, it sounds like the policies and procedures, if we
we
decide
go,
on a
that's
piece of
just
software, that's gonna be a huge piece of it right there, because
It's
that's
just
what
a
gets
lot.
printed for med staff, and then it also gets printed for, for our meetings too.
Right.
So
So,
allow us the ability to kind of get creative.
to a
I
certain
just want to
extent,
point out that we do.
I do think for my own purposes, being able to see the financials while we're talking about them and have that on something that's printed is helpful to me. I don't know if anyone else.
Perhaps big things like
feels-
this, though.
But stuff
could
like
go
that, no, I don't think
electronically.
needs to be.
Yeah, I'm not saying eliminate paper altogether. Like me, I still like a paper book. I'll be honest with you, I like a paper newspaper.
Mhm,
Yeah.
It's just comforting, I don't know, but I'm weird that way.
I do
Um,
both, but I prefer paper.
But we do need to pay attention to the amount of paper that we go through and the amount of, and it adds up. It's really expensive.
And
Agreed.
time.
And the
Yeah.
time for
Oh, yeah.
copying everything, yeah. So,
Deborah's mental health.
yeah.
And
Bye-bye, Ken.
also too, as soon as the board meetings are done,
Goes away.
anything that's
So-
not, that is, you know, open to the public gets shredded, so we're paying for shredding as well.
Yeah,
Yeah.
so we're gonna get creative and see if we can't do some cost cutting and maybe some more efficiency.
Yep.
Okay, that's my report. Any questions?
Thank you.
Any other questions?
Nope.
Okay, thank you, Sean.
Yep.
Okay, next up, CNO report, Judy.
So, at the time of this report, and I think we're still there, all counties in California were listed in the low state for hospitalizations related to COVID.
Question, before you go on that. Is the state tracking hospitalizations related to flu or anything else, or just for
Yes.
COVID?
They do.
Okay,
Yes.
Okay.
but, as far as how we, do our visitation, our masking policy, et cetera, is based on whether we're in the green zone, the yellow zone, or the red zone.
for COVID, but not necessarily for flu.
Right, but we are now officially in flu season, and so flu is being reported, if we catch it.
Right.
Some of it's just, maybe you have the flu, I don't know, but we know that you didn't have COVID.
Right.
Gotcha.
And we have started doing our flu vaccines with all of our employees, and so that's underway. We had our public flu clinic yesterday. And
Was it well attended?
you know, I don't know. I
Okay.
didn't hear. We were quite busy yesterday, but it did happen. And we will still have flu vaccine available. And the pharmacy has flu vaccine available as well. We
So
did,
Are we giving
probably
flu
get
and COVID together, do you know?
you can.
Yeah.
Yes, it's fine. And then, based on your request, we did have these, Chelsea did a beautiful job of creating these flyers. We printed them two-sided. And so, we were handing these out at the flu clinic as well. And so,
Awesome.
it lists all of our new providers that are accepting patients right now, and then talks a little bit of the benefits of establishing a primary care.
Nice.
That's fabulous.
Very nice.
That worked out
We will
beautiful.
have these available now in the emergency room to give, if it's not established. We'll have them in our walk-in clinic, and we'll probably be posting something very similar in person form around town, like at Holiday Market and the post office, et cetera, so that everyone knows that we have these providers, and hopefully that's the beginning of our real push to say, no, we really have providers.
Right.
Yeah.
Good,
Right.
good.
Ours. And so,
Will we be putting that up on our website as well, and social
Yes.
media and?
Yeah.
Excellent, I love that.
isn't that?
It's
great?
really
It's
nice.
really great.
Yes.
Do we put a lot of things on Facebook Live?
Oh, yes,
Mhm.
we do.
Yeah. Continuing education, we did hold our mobile intensive care nurse, our MICN class, NorCal EMS was here. We had 4 nurses go through that, and now the last part of that, everyone passed the exam and all of that. The next part is that they have to do an ambulance ride along. And so we've been working with Chester Fire and some other EMS agencies and others to facilitate, so what they have to, be in the back of the ambulance, they have to see what the layout is, the equipment that is mandatory for NorCal EMS, medications that are carried, but what they learned in the MICN class is actually the paramedic protocols. So now they'll be more comfortable if we need to send a nurse down on an interfacility transfer, what have you, they will know
Nice.
exactly. Also, when the paramedics are calling into us, regardless of what service they're with, they understand the protocols, so they can question, well, did you give the aspirin or did you treat with nitroglycerin or whatever it is? They know those protocols now, they know when to intervene, and they can actually give paramedics orders over the radio if necessary.
That's
being
great.
MIC.
Wow, that's really great.
Yeah,
Yeah, that's
great class, I'm glad to see it come back.
It's a very tough
It's-
class.
It's a very tough class, yes, and so it's been about 9 or 10 years, I think NorCal said, since they've taught one of these courses.
Oh, wow.
And Seneca was the first one to get on
Yay.
board.
How
I see already bring it back.
Yeah.
And
how often
everybody
is that?
passed, too.
Yes,
That's.
and I'm assuming that they have, that the nurses will go through this periodically. How
Every 2 years.
frequently? Thank you.
Research.
Every 2 years is a research.
I
Very
love the
nice.
fact that NorCal EMS or LEMSA has seen the value of bringing this back.
Yeah, that's
Mhm.
amazing.
Especially with the paramedic shortage.
So now is this, we do or we don't have a clinical ladder? Because this would be this MICN
So,
certification.
We have a little bit of a critical ladder between an RN1 and RN2. And so currently the only RN2s we have are emergency department nurses because we do require quite a few additional certifications to work in the emergency department versus working on the acute care floor.
Sure.
So there's a little bump there. but
Okay,
It's only in kind of its early stages of development as far
Okay.
as a career ladder.
Okay.
True career ladder.
Sure.
Now for their ride along, or, well, I'm calling it a ride along. Yeah, it is a ride along.
Mhm.
Do they have to do that within the NorCal EMS area? So
No,
the protocols might
we
be
can
different.
request, we just ask, say, if they, because they may not get a call in Chester Fire.
Right, that's why I'm asking, yeah. Yeah,
So we've requested, can we use, Enlo EMS? And, that's been approved too.
okay, wonderful.
But what's cool about doing it here, if they did get, is that it's good to see where the paramedics actually respond to locally.
That's true.
It helps you really understand some
Yeah.
of the logistic challenges that our EMS services have
Yeah.
here.
That's very true.
Other rigs are set up, they're not all set up the same, so.
So, and Butte County is actually in a different LEMSA, they're
Yeah.
under Sierra, South Sierra.
Yeah, that's why I was
But the
curious.
protocols are nearly identical, there's only a few subtle differences between the
Okay.
protocols.
Okay, yeah, cause I was just thinking 4 hours might be kind of hard to get here, cause,
Yeah.
and how sporadic would it be to try and get those hours? Yeah.
So if they don't get any, then what they do, they still have to log their time, that at least they were hanging out at the fire station or what have you. But during that time, it's expected that the paramedics would actually be drilling them on different
Mm.
advanced life support scenarios. Okay, you've got chest pain, and what are you going to do? And what are the medications you can actually
Mhm.
deliver, et cetera, et cetera. So they run through those as if, in a simulation type.
Mhm.
Okay, that's great. Thank you.
This is also gonna be great for when really truly established run reviews.
Mhm.
They should be part of that run review. And so, when we get those established.
So they enjoyed the class, they actually wished it had been a lot longer.
Really?
So under nursing recruitment and workforce and our lab manager did submit his, he is going to retire.
Did he give us a date? Did he give us a date, or is he gonna wait until we?
He originally gave me November, and then I cried a lot, and then he said, okay, January. And he knows it's going to be difficult to find someone.
Yeah.
We did have one interview so far this week, but the person was not.
Make
did
sure
not
you
bring the qualification.
Show them. That's
So
Yeah.
new
we have
stuff.
an interview coming up next week, so at least we're getting
A few.
applicants.
Yes.
But it's very difficult to replace someone like Dave Mendel.
You
Yeah.
bet.
It really is.
Wow.
And a lot of, people coming from larger hospitals are very specialized, like they may be in microbiology, but they're not in blood bank. Or they may be working the lab bench, but they never set foot in the blood bank. So getting someone who can do all aspects, and they step in to draw blood too.
Yeah.
Mm.
So that's kind of an old fashioned mix there.
Mhm.
So, yeah. Yeah, I don't know what's gonna happen while the baby boomers retire. It's gonna be a
I
sad
was telling
day.
Katie that hardly anybody goes into CLS anymore,
Yeah.
laboratory science. And if they do, they work for someone like Pfizer,
Mhm.
Right.
they go into the big pharma or something, but it's.
Mm.
They go into genetics.
They go into genetics or something very specialized.
Yeah.
So it's a tough one to
It's gonna
fill.
be a tricky-
Well, thank him for us for giving us an
Yeah.
extension.
Yes,
And
yeah.
how many years of service does he?
He's been here for 24 years.
Wow.
He's very good. He's a hard one to replace.
He knows everybody.
Yes, he did.
He's a great guy. So anyway, so we're working on it. I'll keep you updated on that. Also, our house supervisor, Ann Holt, has decided for personal reasons to move to another facility. Ann has just been fantastic for our whole summer implementation through our most recent state survey, just everything. So that's gonna be a huge hole to fill too. But she's a wonderful person and I wish her well. She's really only moving on for better retirement benefits that she can get elsewhere, and I get it. And she's got a long career ahead of her and
We'll
we
miss
wish her
her.
well
Yeah.
as well. Regulatory updates, we did have a 5-member survey team show up a week ago Monday on the 16th. We knew we were due for our critical access hospital survey because we haven't been surveyed since 2017 and they're supposed to come every 3 years.
This DHS? Who was it?
CDPH,
CDPH.
the survey.
So
Yeah.
is it normal for them to have a team made up of
Yes.
this broad of
yeah.
us?
Yes.
Okay.
Oh, yeah.
And then today we have another surveyor who's currently on site with Linda doing our life safety review. Because once your hospital is surveyed, then they have up to 2 weeks in order to complete the life safety
Okay.
survey. So checking all of our systems, our fire, suppression and all of those things. So he's been here all day with her, much to her dismay. So anyway, it was a pretty tough survey. They turned over every stone. And that we had just reviewed over the last few months, the 2017 survey, knowing that that's what they're going to look at. So a lot of people had done their homework and took care of those things, making sure that we were buttoned up there. And even though they were pretty tough on the managers, they fought back pretty hard to protect their departments. And I'm so proud of them. And really, even though they're always going to find something, so they'll stay here forever until
They can't leave with that.
Right.
That's just not fair.
there was nothing related to patient care. There was nothing related to patient safety.
Right.
A lot of it was really due to our outdated facility, our poor storage options. Some areas that are kind of some cabinetry that are a little bit rough in spots that need to be repainted, just to ensure that we're doing really great infection prevention and wiping services down. It was things like that, nothing, it's going to be a paperwork.
Yeah.
It's a homework.
It always
project.
is.
Yeah, but overall, it was a rough week. Had to talk a couple people off ledge a couple times. But they did wonderful and you should be really proud of your staff.
We are very much so. Yeah.
So is there a separate lab survey? Does CDPH do a
Yes.
separate lab?
Yeah, so they went into the lab that we're due for our CLIA survey in January.
Yeah.
And that's another reason why Dave is staying, because he knows we've got an upcoming lab survey. And so he'll stay and get us through that. as
Oh,
well.
that's awesome.
Yeah.
Yeah, very good.
So
So the way we calculate it, we won't get our next survey till we get the survey for opening in the hospital.
Wow.
Hopefully,
well, out of curiosity, if they find something that we just cannot remediate because of our aging facility, what happens with that item? Do they still list it as a finding and then just say that we can't do anything about it? Like what actually?
So we will receive their final report. They have 10 business days to submit the report to us. So we should receive it no later than a week from tomorrow.
Okay.
And then we have 10 days, not 10 business days, 10 days, to submit our plan of correction. And so, I met with all of the managers yesterday. We went over our preliminary findings that they reported to us in our exit conference. And then we just basically went around the room saying, where are you at on this? You know, some of it's just creating policies. It's just a lot of work. And so we're in really good shape as far as that goes. So once we submit our plan of correction, then they will review it and they'll come back if they have additional questions or points of clarification. I don't think there's anything insurmountable here, but we did have to spend a lot of time with them to show them what do you want us to do in this building? You know, and like, what, you know.
So these were
we
new.
can't coach you.
So these were new people who
Yeah.
launched, these were new people who hadn't come out to our site before then?
Some of them were brand new,
Okay.
yes, and, but one I worked with quite a bit, at Enloe, and the pharmacist I worked with at Enloe.
Okay.
But his findings were minimal too, and I'm telling you, this guy is a stickler. And, so.
It sounds like
we
we're
feel
doing really
good
well
about
then.
that.
The
Good.
life safety though can be tough.
Yeah.
That,
But
with our,
Linda's-
Linda,
with our
Linda is
facility.
so good with the life safety being,
Good.
so we'll see how that comes out, but we generally don't have an issue with life safety.
So anyway, more to
Yeah,
come on
we'll see.
that, once we get the final report, to see if there's any surprises in there. But otherwise, I don't think that there's anything that, for the most part, almost everything has already been corrected. We just need to see which policies need to be either revised or created. It was about, infection prevention rounding. And, so they were really, really focused. One of the lead surveyors was an ex-surgery, so they come in with their very biased
Yeah.
things, and so, but our infection preventionist in the past has never gone into surgery. It's usually a closed unit,
Right.
and surgery takes care of that. They didn't like that, so we're changing our rounding for
Okay.
how we're going to do our surveillance in the kitchen and through the rest of the hospital. So minor tweaks of, what our process was, okay, we'll fix our process. So it's really not a big deal. Again, they did wonderful. Our staff did wonderful.
Thank you.
Thank you. It's great.
Any questions?
I don't think I have any additional. Do
No.
either of you? No?
Good
Thank you.
job.
Appreciate it.
A lot of work.
All right, next up, we have Steve. Are you on the phone?
Yes, I am.
All right, your report, please.
Yeah, so let's see. Can't see what is being projected.
So cash equivalents, Steve, right at the first one.
Tab G. Very good.
Yep.
Thank you. So I've just, I'll note that this will be the last month of this presentation. Starting with the October meeting, we will go back to regular financial statement presentations. I need to have our financial statements through September 30, so our first quarter, to the state and also to our underwriters, Piper Sandler, by November 14th. So we'll have that for sure, and then hopefully something else doesn't come up and push things aside, and we can get back into our excuse me, our regular monthly presentation, as November's a little later in the month, November 30th, so it gives us a little extra time. So this will be it. As reflected here, we did have a decrease in cash. In previous months, I had mentioned some of the things that contributed to the decrease in cash, and this month it's pretty simple. Almost certainly with the revenue level we had for the month of September, we will have a loss, couple $100,000 loss, which is the expectation. And we still are collecting our AR a little bit below our net revenue, a little below our historical percentages. So those two things together pretty much are the components of our decrease in cash for the month. September, the revenue, this includes long-term care as well, just over $2 million. was a little increase over August and only 30 days, but it was a decrease over September of 22. In comparison to September of 22, it was both from the inpatient and outpatient side. September of 2022 was a bit of an anomaly. We had nice inpatient volume, and we had some outpatient services that we don't experience on a regular basis, mainly IV therapy services, which come with expensive pharmaceuticals. So that September 22 of 2.4 million, that'd be nice if that's something we could replicate, but that was a little bit high in relation to what we normally run. AR collections, although they were down a little to the average, 961 is still a pretty solid collection for where we're at with Cerner. When we look at the AR, third-party AR, we still have 2 AR sources winding down the old CPSI Evident, and then what we're generating currently in Cerner. This is only the third-party AR, so this is any third-party payer, Medicare, Medi-Cal, commercial insurance, etc. So in CPSI Evident, we're down to just under $250,000. We have had some nice collections, very nice collections in the month of October, both in Evident and Cerner. And so the Evident CPSI AR, when we meet at when we present October's financials, should be under $100,000. And when met with them, the HRG company today, we anticipate winding down all the AR by the time that they end their wind down, I guess, for us, their work for us at the end of November. Cerner grew a little bit. I did a little calculation there on the AR days for Cerner, 57. That's a little high for us. That does not include long-term care AR. So as we discussed on Tuesday, that we may be collecting at about a 75% rate of where we would want to be or expect to be or need to be. But we've seen significant improvement in the month of October. And the biggest area where we have seen traction, if you will, in the good Lord help me, in the AR collections is long-term care. We finally have started receiving payments from California Health and Wellness, Medi-Cal managed care plan. And actually this week, I think I mentioned to you all that there were there Tuesday that said we have a big check on the desk in finance, and it was indeed a big check of $302,000, and it represented payments both from the CPSI, and it also represented more significantly our first payments through our new long-term care billing system, AmeriCare, and that was incredibly significant. So Partnership Health Plan decided to rain on our parade and denied our claims from AmeriCare. So yeah, it never stops. So we'll be appealing that, or just sending corrected claim. It's not really even appeal. It's they didn't like something on the claim. So we'll be sending that back, and then we'll be billing out September when we get that issue resolved. We'll be rebilling prior months for Partnership, and then billing out September for everybody. And then again, billing out October here shortly. So I think that October is going to present a much better AR and cash picture. So let's see.
Thank you for clarifying that, Steve, because I don't know about the rest of the board members, but I was a little concerned looking at this.
Yeah. Like to know.
Yeah, us too. So, but yeah, it's.
So Steve, I'm sorry, I'm gonna interrupt you really quickly. On the second page, there's a few lines that start SNCA. Can you please tell me what that stands for?
It's what Cerner calls us.
That's what they call us?
Yeah, Seneca, California, California.
Oh,
This is then, oh.
okay.
Seneca,
That's us.
PC.
Primary care.
Primary care. And
Yeah, so
specialty,
SNCA from now on,
therapy,
you'll see
and
that. That's
walk-in.
Seneca.
Yeah, I got the second part of it, but I wasn't sure what the SNCA. Thank you.
That's their abbreviation for us.
All right.
And it's really that the report is generated out of Cerner, and this report is a pre-done report, and so I just left those headers on.
No,
so
that's fine. I just
No, it's just the way
my own
it's-
application.
It's just the way it generates out. And, I think we're going to, all of the board members probably going to get used to it, is that we're going to be able to generate reports out of Cerner for a variety of reasons and information. And so this will be, we don't have to take data from one place, put it in another place. That's a really nice thing about Cerner. So
Yeah, no, I like this report. It's very nice and clear.
Well, and I asked about the PC, so the PC makes sense for primary care provider. What's specialty primary care? What's TH?
telehealth.
Oh, okay. And then WI?
Walk-in.
Oh, that's the walk-in, separate, okay. Thought maybe that was under provider locum above, and then that was 0. Okay.
And the other provider is in September of 22, Stephen Hayden was out for a bit, and we had providers come in that were dedicated to the walk-in, whereas I don't know, the way Cerner registers, this idea of a patient coming into the walk-in, I guess if they get registered in the walk-in and then go ahead and are transferred, taken to Dr. Russo or Heather Smith's office, then it looks like a walk-in visit. If they just take them straight from the walk-in without registration, then I believe they'd get registered in that location. But
But to that point though, they're not getting double counted, right?
nope, they only get registered once.
Okay. Thank
So
you.
it's the idea of tracking, as Sean's talked about, and Judy, the idea of tracking or showing that we can support the walk-in with other providers. So it's kind of a weird year over year, if you will, because in last month we just had our doctors just picking up a patient here and there, whereas in the 2022 we literally had providers that were based in the walk-in and seeing all comers. So just that's why it makes comparison very challenging sometimes. So
Our utilization overall is up year over year though, so that's a good sign.
yeah, I don't know, it was interesting, I guess. If we look up why we saw so many people in the walk-in, our primary care was down 170. So that's a very, very good thing that year over year our primary care visits were up at 170, and it was really having Dr. Russo here and Heather Smith here. So very important.
So Stephen, looking at this, page 2 of 2, under the walk-in. So now am I interpreting this right, that there were only 3 patients that were funneled to Dr. Russo and Smith that could not be accommodated by Stephen Hayden in the walk-in?
No, not really. Maybe I don't want to say that without really knowing for sure. What that means, at least in my mind, is that there were 3 patients that were registered in the walk-in and then treated by 1 by Dr. Russo and 2 by Heather Smith. There may have been others that just were sent straight back. They came into the walk-in, maybe there was nobody there at all, and they just said, we're going to register you with Dr. Russo. He's ready to take your register with Heather Smith. And then they would be registered to their office, but it's just this location thing. And so I don't know that we've got it all completely ironed out, nor have I. Me certainly.
It would be registered that way, would show up on the doctor's calendar.
Yeah, so just Steve, I'm just gonna take a pause here for a second. So we're gonna be devising a little different look for the walk-in, where on certain days, physicians may rotate through the walk-in, right? And we have to work through some things with Cerner too, rather than assigning it to a position on the schedule, we have to be able to assign it to the physician, whether they're walk-in or not. And that's something we've got to play with so that these statistics are correct. Right now, it sort of assigns it to whoever was this, how it's scheduled and things like that. So we're tweaking it a little bit so these statistics are right and reflective of who's doing what in the clinic,
Okay.
regardless of where they are.
Okay.
And that's really where we want to get. We want to look at true volume by clinician. We can look at the schedule and say, oh, they were in the walk-in that day, but it's irrelevant. I want to see how each one's performing individually.
Okay.
Yeah.
And we're having to tweak the system a little bit.
Okay. All right. Okay. Thank you.
Yeah, it's work in progress, Shelley. That's Steve, sorry.
Nope. Always good when we have an opportunity to have a open dialogue about things. So that's really all of the information for the September financial report.
Steve, are we able to get same kind of information for the hospital? Hospital visits and inpatient information as well? Maybe.
A
Steve,
dashboard.
I'll show it to you. We should be able to run this with the location of ED. It'll do the same thing out of this report. So
Not as slick as this.
Yeah.
So the nice thing again about Cerner, it's all there. I have to work for it a little bit still, and that's maybe just because I haven't, like Brian says, I haven't immersed myself into some of the reporting there. I did not produce this clinic report. This came from Jessica Corbett.
And
So-
and we, just so you know, the reporting, so everything's in Cerner, extracting it as you want it is something that we actually just hired for. We hired an analytics person. So to be able to, once you make these reports, we can make them standardized reports.
Mhm.
So that once we tweak them and get them right.
Yeah.
You'll start seeing us using Cerner more to define certain areas within the hospital. And they'll come out in standard reports. Right now, we just literally doing our reports we're just learning how to do them.
Do we have a dashboard? Because dashboards
Yes.
are, they're just
I've asked for,
so insightful.
you're going to start seeing nice
Total
colorful
number of
lines
pages,
and
total number of-
red, yellow, greens.
Yeah.
So we just talked about graphing these things, these
Yeah.
reports into visual references versus looking at all these numbers. Are we up or are we down?
Right. Right.
And if we're down, why?
Yeah.
The trend is, and that's what we want to start providing in the future to the board, is a snapshot, visible snapshot as to how the health as it relates to volume within the clinic, volume within the ER, those types of
I
things.
thought there were cans. Aren't
There
there like
are.
canned dashboards?
you can reports, lights on is a facility-wide view. DA2 digs into the details a little bit more. I saw a presentation of another tool that we can evaluate that really kind of breaks down granularity. You can look at Doherty, the EKG time by triage nurse.
If we could,
Well, I'm just talking about for the board.
No,
Yeah.
no,
For us, I
but
mean,
that level of detail data is
It's
in there.
so helpful.
so see, for board reports, I know that you want to see clinic volumes, you want to see trending in clinic volumes by provider. That's good.
Yeah.
So if there are reports that the board wants to see that I can build for board reporting, things specific, then let us know what those are specifically, because we can build custom reports.
I think it'd be helpful for me to see what is currently in existence to even know if we have to build something custom.
Oh yeah, we looked at lights on to see if there's something in there that would be valuable. I mean, maybe we could sit down, Brian.
So do we have any kind of a dashboard now?
There are
Already built?
some generic ones, and you benchmark yourself against other similar type of facilities in the Cerner world. And we can set our own baselines on some of the metrics to see how we're trending with what we expect our baseline. to
Yeah.
be.
I mean, what I was used to seeing, there's a Starter facility.
Yeah.
At the management team meetings was a dashboard, and you probably saw the same thing. Month to month, you had inpatient admissions,
Yeah.
you had
Right.
surgery volume,
Yes,
you'd have all the different programs and the utilization. And you could see denials. There was discussion about that. There was AR. I mean, it was a fabulous report.
yeah, there's operational dashboards, scorecards, dashboards, is executive level dashboards, you know, we've got enough data in there to kind of start going in, setting
Yeah,
benchmarks
so just do.
and validating, the thing, you know. Part of the problem with Cerner is some of the volumes, some of the areas are so low that one outlier can really skew data, so,
Pretty
you
low
know.
end numbers.
Maybe I can
Right.
sit with you, Brian,
Yeah.
and we can kind of, I can.
Absolutely.
Yeah, I would love to find out which ones in there,
Yeah.
but then we just run them for the board meeting.
Yeah.
You stick them up there and it's easy for everybody to see, it's easy for the public to see, turn them up, we turn them
Oh,
down.
yeah,
You know,
They're
those are the
great.
kinds of reports I'm used to as well.
yeah,
Just a dashboard, so I could do a snapshot, look at it, if I wanted to dig into it, I
yeah,
can.
yeah, but we're getting there. So,
Oh, yeah.
Yes, we are.
Yes.
I just,
yeah,
there's lots of data, yeah,
Good question.
all right. Yeah.
Anything else, Sean, or I'm sorry, Steve, do you wanna go on move on to the R1 report, or? do you- is there
Yeah,
any-
just one comment, Jerry, is that I've kept my previous board reporting format, including statistics and everything, and I pull the data out of Cerner and put in the stats in the same format that we've historically done. So with the availability of a different type of presentation and format and all that, I'm certainly open to any discussion about what you guys want to see. So within my report, so just maybe we can discuss that as well at the treasurer's meeting. But I'm fine with changing it if you'd like to see it differently. So
So my perspective is on like the R1 reports around AR days and denials, and you know, this is something that visually referenceable would be great.
Mhm.
You could say, here's our, we want 12 days in AR. That's our benchmark. I'm making that up, obviously. Ha ha ha.
I'm like,
But-
I love
Dream
12
girl.
days AR.
But if we have that line going across as our 12 days and where we are, just like this report would be great or something like that. Because you can see if our AR are going up, down, you know, our denials. They do have a little thing in here. You can see the little graph for denials. So we're going to continue to tweak these reports until they're just really easy.
I like the report, the R1 report, frankly, except for
And
stretching it across the
they-
rest.
they-
making
they
it
have-
Bigger.
they have their own reporting, but they also go into lights on as well.
Yeah, they got lights on.
Go ahead, Steve.
okay, so that's it for the September report. Let's go to R1's report. You know, it's kind of unfair to even talk too much about the month of September because holy cow, like I said, what a big improvement. So what I would,
October.
yes,
Yeah.
already through October, yes, in the big areas of concern. But one thing, and we talked about this at Tuesday's meeting, our one thing that is really, it's I'm sorry, I'm looking at the actual slide. Let me so I can get you guys to
Number are
work.
you on?
Don't worry. Very nice. Oh, is it? Oh, the PowerPoint went out to the. Oh, okay, great.
Okay, yeah,
Yeah, slide 4.
okay.
So the DNFB scorecard, DNFB standing for discharge not final bill. It means the patient has finished their care. They've left the facility, and now we're just waiting to send out a bill. And this is the biggest hang up we have right now with Cerner, that we're getting claims held up. So with, and you can see there that our days at September 23 we're at 28 of discharge not final billed. A big part of that is this held in scrubber thing. Good Lord.
Yeah,
You know,
what
all
happened between August and September for that?
What's that?
I'm wondering what happened between August and September for the scrubber.
What happened is that we I think we are talking about this on Tuesday, that Cerner has these rules that they create, and so the rules will make a code be added, a code be withheld, and when they'll withhold these rules for a long time so that we can manually put them through the system and then send them out, and they'll go out clean. But sometimes when we turn off a rule, or it happens, something happens without our knowledge, and a very significant rule did something that, led to a huge number of our claims getting held. And so we just had to go in there, fix it, and release it. So this was just a temporary thing because we were pretty steady where we were at, and so this has gone away. This was fixed.
But Steve, was this a new rule that went into place? I'm still not quite understanding the jump.
Well, I'm probably not explaining it very well, because it is a bit of a voodoo, I guess, with how it works. But the listening to the conversation was that they either the rule failed, or the Cerner was directed to turn it on, turn it off, and because we're going to send a bunch of claims through, and it had to do what it needed to do. So that did not happen. And when that did not happen, all these claims went through and they got held up in the scrubber. It was a very easy fix. And then once it was fixed, they resubmitted the claims, and then they went out.
Okay.
So I think the moral of the story there is you just have to have your eye on it every day. Somebody has to be watching this.
Yeah,
just
somebody-
constantly.
Okay, good to know. Thank you.
So, but there's still some things going on with discharge not final billed. We talked about it in a little bit of detail on Tuesday, that we're looking at two things. One is providing some immediate coding relief to help the backlog of stuff that can go out, because the way that Cerner works, as we talked about, everything flows through the system and ends at coding, because coding's the one that releases it to the claim to be billed. And so it gets to coding without a lot of scrutiny, if you will, because that makes sense, because if you're sitting there looking at every claim along the way, then we're back into CPSI evident. But if our workflow process is flawed, or there's some problem with the way that the system's working, people aren't capturing charges, they're not putting the proper documentation in there, whatever it could be, then it ends up with coding. Coding has to sit there, figure out what's going on, route it back to the right person, or try and fix it themselves, as opposed to just taking the claim and putting their code on it, doing their regular job, and out it goes. So
Steve, I'm sorry to interrupt you for a second though, but will you explain what the bill suppression hold is, what that category is?
yeah, a bill suppression hold is where we basically said don't send it out. So the biggest
And
thing,
we're not ready to send it out because we're trying to get
Missing
things worked
coding,
out
missing something. Yes.
with
And-
a partnership or whoever.
a partnership or whoever. But a big example of the bill suppression hold is right now what we're experiencing with Almanor Physical Therapy, that Medicare said Steve Brown is not credentialed with us. We don't recognize him. don't send us a claim or we'll just deny it. So we've had to sit on every single one of his Medicare claims until we can get him credentialed. So that's an example. There's other things where I can't think off the top of my head some of the things that lead to a hold that we put on them. So
Okay, so when we're talking about having delays with coding, is that strictly just the category waiting for coding, or are we talking
no,
other those categories are included in that?
yeah, there's detail underneath waiting for coding, and it's really unfortunate because that's just an unfair characterization of what's going on. So things, the way that Cerner works, and Brian can, say it better or differently, is when there's a claim, it gets categorized based upon, or an account or whatever you want to call it. It gets categorized on where it's at, what its current condition is, what the notes that have been put on it, and then it gets put into what's called work queues. And so there's a work queue for waiting for coding, and underneath waiting for coding, there's a whole myriad of things that are that fall into that category. One of which is actually waiting for coding, but it's just kind of a poor representation of what's going on. I can certainly bring one of the reports we get, because when we meet weekly with R1, they'll give us a detail. Well, they can give it to us anytime. They give us the detail of what's underneath. They'll show us all the individual work queues, the amount of claims that are in there, and the number of claims and the dollar amount. So, and that's how we go in there and we look and we say, what's really going on there? What needs to happen?
So let me ask you this question, Steve. As I'm looking at the bottom line on here, less standard delay, it says 1.4 million. We were talking about having a special meeting potentially to get some help. Is that help going to clear $1.4 million?
Not all of it. I
Okay,
think
how much? Give me an approximate.
So let's just throw out a third of it. How's that? So what it'll do is it'll be able to push out a third of it. What that allows is the coding people to continue to work the accounts to identify what the true condition of the account is, what needs to be done, and who needs to do it. So if we can keep moving the claims that are good, then the DNF, when I say a claim that's good, account that really just needs to be coded, then the DNFB will not keep growing. So we'll start knocking it down and it won't keep building up, if you can visualize that dynamic.
Yeah, if I could.
What's happening now is we're trying to resolve these claims, and we have these issues, and then the work queue is populated with more problem issues, but at the same time, it's also getting populated with more clean claims. So if you take away those clean claims, then the individual can work more on the workflow issues. But what we're hoping, Jerry, as we talked about, is that if we can spend more focused time on those problem issues, then we can go to root cause, or however you want to look at it, and stop those from getting there and backlogging in the inventory.
This is, if I could just metaphorically kind of paint a picture, because it's the only way I can understand half of this stuff. So in Cerner, physician documentation is where the glacier melts. That's where I consider the glacier melting, right? This has got to be done well, right there. They've got to document properly. They've got to capture problems lists and things like that. So that's the glacier melting. And when this is done right, that water flows downstream. It goes into buckets, and that bucket right now is overfull. It's overfull with, they're not doing it properly at the glacier level. So it's the water that's coming down there goes into two buckets: clean claim, which is like, it's actually going to be good, and then problem claims. Right now, they're both full. So we're trying to get help to get the clean claim bucket right. Steve, clean claim bucket cleared, so that we can continue
and
problem
not
bucket.
Yep.
Okay. at the same time, fixing where the glacier's melting.
But why are we touching a clean claim in the first place? If it's a clean
It
claim,
always goes, go ahead, Steve.
They have to add codes to it. There's certain things that the coder needs to add to a claim.
Little things that they check it. Basically, it's a quick check.
Yeah.
And they should.
Everything is there, good, we can ship it off,
Right.
Or
but someone's gotta look
Add an
at
A
it
code
first,
or
to
something.
make sure.
isn't that what our
Or
software's
system.
supposed to be for? I mean,
They
What's that?
use software for it. She uses a 3M coder thing or whatever that applies the code. And
oh, I
she
just
could
seem to
explain it.
recall Cerner are supposed to be doing all of this stuff for us. That's what I recall, that, it was a clean claim, it was supposed to go off to the races and we
it's
wouldn't have
always
to
gonna
mess
be,
with
it's
it.
always gonna be held for a look. That's the way it's designed. Let's take a
Okay.
look, see if we can add something special.
All right, so in September, we had Held and Scrubber 729, and those we have been resubmitted for October, right? So that leaves us still with approximately 700,000 after you look at the less standard delay. So.
Yeah,
we're
Jerry, the
hoping-
last update I have, I don't know why I only have this, an update from October 11th.
Yeah.
Held and Scrubber was down to 317 already. The discharge not final build was under 1.3 million, so it had already dropped at 300,000.
Okay, so we're talking about getting some help to hopefully clear approximately 500,000.
That's a rough number, sure. I can come up with a better number than that.
No, I just was throwing out approximately what I thought I heard. Okay, all right, that helps. Thank you.
Cause you said there were hundreds, you said there were hundreds of claims, related to the problems list issue.
Yeah.
In the AR, so that's what Judy's person is gonna help with. Does that equate to the 500,000 or 300,000? Those 300 or hundreds of claims?
Yes.
Okay.
Okay.
They're mainly all clinic claims, what I've been told.
Yeah, so Brian and I had a conversation today about focused retraining. Focused retraining to where the glacier melts, where it's happening with the clinicians, that's what has to get fixed.
It's
I-
sequential.
I thought it was ER
It's-
physicians.
It's mostly, it's a lot of ER.
It's still sequential. Problem list, if you do the problem first,
Sure,
when you do your orders, it attaches the problem to it. So then the coders don't have to attach that code to
Yeah.
the order.
I just didn't realize it was also a big problem in the clinics.
I'd say
I thought-
lesser,
I thought
but
a lot of it
ER is
was
a big one.
the ER. that was
Shelley,
Tuesday.
Shelley,
Yes.
don't let me misrepresent things, please. The clinic claims are the ones that are good to go. But because of the focus on the stuff mainly through the emergency department, are the clinic, there's not time to get those clinic claims out. And the ER claims, hospital claims are bigger dollar claims.
Yeah, we're focusing a lot of our attention on
Thank you for clarifying, because I had the same question.
Thank you.
All right, go ahead, Steve. Is there any other parts you wanted to highlight?
Oh, yeah. So slide 5, claims processing. We use the term clean claims rate, which means what is the percentage of claims that will go, when we release it to our clearinghouse, which is the one that scrubs it being, it does a review for compliance and the presence of the things that are needed to get paid. And then it also is the mechanism for submitting it electronically to payers, third-party payers. We have a initial target of 80 to 85% clean claim rate. Best practices is 90%. We've been running at this 60% for the last couple of months. After seeing some of the improvement in October, I said, can you please run the year to date or the month to date through earlier this week? And the clean claim rate through last Tuesday or last Monday is up to 76%. So that's very, very significant. And that just, speaks for itself, kind of thing. We talked, go into slide 7. We talked about denials. Please don't ask me for the details behind these items. There actually is a slide behind it that's really hard to read that goes into a little discussion about it. The denials peaked in September, or got the highest since we've gone with Cerner. A lot of it's due to the volume of claims we're getting out, and denials percentage. We want to be 5% under 5% or under. So 22.8% obviously is a unacceptable number. So I asked for and I asked for an update again through October. We're looking at about a 40% decrease in this amount for October in dollars, and we're looking at the denial percentage, provided that we experience the same we've had through the first 21 days or the first 2/3 of the month. That's assuming we'll have the same denial experience, both good or bad. Our denials could be decreasing. I don't anticipate anything causing them to increase. So it brings our denial percentage down to 14 or approximately there. And so, still above our target, but it's trending in the right direction. And I think
Our target is 5%. Is that what you said?
that's a target. That's a best practice type target.
Okay.
But there's no way, we're going to hit that when the best example I can give of that is we've been billing Medi-Cal for years and years and years for long-term care. And as we tried to start getting claims through AmeriCare, it was like, it's like we'd never billed Medi-Cal before or something. We just say, here's the numbers, here's all the fields we populated, here's the information we put in, rejected, denied, it's a head scratcher. So trying to set up a new system comes with its limitations and challenges, but again, it's just something we stay on, and we are certainly seeing a significant increase in cash. October will be far and away our best collection month since going live with Cerner, and above our average with CPSI. So, but you just can't take a nap on this. And thank goodness we have a good partner, because if we had to do the heavy lifting on this, it would consume us. And so we're very fortunate that we have people. We have to monitor them, but they do the work. So I don't think there was anything else. There's a bunch of information. Slide 11. This is talking about work queues. So this is where all of the things that there is either an edit through the billing, a denial. These are this is the referral activity on all of these things in that first column to the left under total client assist. So these are the types of things that R1, our vendor, our partner, says, hey, this is what's happening. Either it's happening in the clearinghouse, billing scrubber, or straight through a denial rejection. So this just gives you an idea of the incredible amount of things that are going on in this little hospital.
Wow. Sure does.
So obviously we want to see you know, that all of our stuff, all of their requests for us to do something is getting resolved within a very short period of time. Just not possible right now. I mean, the sheer volume of things we're dealing with is, and that's why I'm saying with our coding people, for them to be freed up to deal with this stuff. And some of this stuff isn't even, you know, specifically theirs. They may see something and say nope, and move it to someone else's work queue. So yeah.
Anybody have any further questions for Steve on this? David, do you have anything else you wanted to add?
No, the only thing I'd say is that if we would like to have our team leader from the R1 group actually come in and do a presentation about, basically do their presentation, because they certainly can speak to it much more
Speak to the
clearly
detail of the different
and
categories and
technically accurate. Plus, they could just go right on their computer to the detailed data behind all of these slides. These slides are just fed by some, you know, database spreadsheet. So when you say, show me waiting for coding, what's all the things in there, they can just pull it up. But I don't want them to make the presentation on a regular basis. I think we can do that, but it just as we're going through this initial time, if there would be something that you guys would, if you think there would be a benefit to having there, be great education regardless. I'll just put that out there to you all.
interested board members?
I think for right now, this is sufficient.
I do too.
For me. I've worked with R1 before. I think some of their stuff about continued explanations. I think it can be helpful too.
Right.
You hear that, Steve? It sounds like perhaps not at this point in time.
Okay. But what I will do is I will ask them for the data behind their presentation so that I
Yes.
can at least go through it a little better and a little deeper and be able to speak to it, you know, from a very, again, clear and technically accurate perspective as opposed to a anecdotal almost kind of thing. So I will do that.
That sounds great. Thank you, Steve.
You got it. Thank you.
Okay. Well, that brings us to number 18, which is our departmental documents and reports. And we had several reports submitted, which I greatly appreciate. Looks like next month we'll be having a closed for compliance. And let's see. I like Steve. I liked your summary in the newsletter, in the staff newsletter.
Thank you. Yeah, it was pretty amazing what Judy and I both talked about that when we looked back about where this year went. So
Where did it go? And we also have our marketing PR report too. And I went through all of these. I don't think I had any specific questions on any of these, but I greatly appreciated having them to review. Did any of you have a question or comment?
No, I just think it's nice to have them. So.
Very nice, yes. Thank you. Thank you to the staff that provided those. Okay, so I guess with that, we shall adjourn to closed session.
Yep.
And Shirley, I don't know if so it's not the same